Going to discuss on section 2, that's communicating bad news. We have Smriti ma'am as our faculty today. Smriti ma'am, welcome to the session. Happy to see you again. And Ms. Manisha is here, our facilitator. I welcome you, Manisha, for a brief introduction of the session. Please, Manisha.
Thank you, Zinia. Thanks everyone for joining us today. So a wonderful good afternoon to all of you. So we have a few more people joining us. I think they'll join in the next few minutes. Thank you, Smriti ma'am, for joining us today. And we're so happy to see you again and so happy to hear from you. So yes, today's session is communicating bad news, and hope we'll have a good time of learning and a great time of understanding a lot of concepts which are very important in palliative care. So over to you, ma'am. Thank you.
Thanks. Thank you, Manisha and Senior. Like you said, there are still people joining, so shall we just give it 10 minutes longer?
Sure. Thank you.
Okay. All right. Maybe we can use this time in a recap, also to respect the time of people who have come in here on time. So in our last session, we talked about communication, the basics, and we talked about who does the communicating, what are the contexts in which communication takes place. We talked about why effective communication is important, and what are the different kinds of decision-making processes that happen. So there's clinical level, there's medical, there's paternalistic, there's shared decision-making, and what we aspire to in terms of getting to that point of being able to do shared decision-making with our patients and their families. We also talked about what communication looks like at the time of diagnosis, treatment, and prognosis. And in terms of arriving at particular interventions and goal settings, whether the patient has decision-making capacity. If they don't have decision-making capacity, then what happens next? And finally, we talked about why communication is often. Sorry, is everybody getting an echo?
No, ma'am. Actually, this might be the issues from his side, I think. Your voice is clear.
All right. Mohan, if you can just check your audio from your side, please, that would be great. Okay. And yeah, coming back to this, we talked about the different barriers to effective communication and why that is why that happens. So we talked about barriers that were professional from the side of the caregiving team. We talked about barriers in attitude. We also talked about barriers that are a result of the environment and barriers that emerge from the patients and families themselves, along with social and cultural barriers. And we also talked about whether literacy has an impact on the way somebody is able to communicate effectively or not, or to receive information that is given to them. And finally, we did talk about distancing behaviors and how sometimes as a subconscious process, especially when it's an uncomfortable conversation, we ourselves employ distancing behaviors that puts a barrier between us and the person that we're communicating with. So that's where we stopped the last time. And I'm just going to pick up from that. So there was a couple of things that I wanted to share with you. If I remember, this is the slide at which we stopped, where I had actually asked you to think of a time when you had experienced communication as being not very effective, or when you had a bad experience in terms of someone communicating with you. So the last slide that I had shared with you last week is this one. Okay. Yeah. So now we're going to move into just a couple of more. We're going to spend a few more minutes on distancing behaviors. This is something that is, I think, important for us to pay attention to, that one way of distancing ourselves is to pay selective attention to safe physical symptoms. When I say safe physical symptoms, I mean symptoms that are tangible, for which there are clearly defined interventions that will actually give them relief. So, for example, a patient will say, "Doctor, I am so worried, I can't sleep properly. I also have back pain." And the person says, "Tell me about the pain." But sleep may have many reasons. Bad sleep may have many, many reasons. And to really understand why somebody is not getting good sleep means having a much longer conversation, right? So, what are your stressors? What did you eat? Is it your nutrition? Is it something else? Whereas pain, I can manage pain. I know which medicine works. So I'll focus on the pain, get the pain out of the way, feel like I've done a good job. Patient feels like I've done a good job, but we have not talked about the other symptom, which the patient actually was the first. That was the first symptom that the patient talked about. So paying attention to safe physical symptoms. Other forms of distancing behaviors is philosophizing, very rampant in our culture. This is life. It's all part of God's plan. Where we philosophize about the person's condition, and even saying things like, uh, one day you look back on this and you think how brave you were, things like that. So philosophizing away a difficult situation in someone's life, moralizing, and this is something a lot of us are guilty of. Cancer patient comes with cancer of the throat, with the throat or mouth or lungs or whatever. So how many packs of cigarettes did you smoke? And adding to the guilt and moralizing about vices or bad behaviors or things like that. Another form of distancing is asking leading questions. You're feeling better today, aren't you? A leading question basically leads the person right to the answer that the questioner wants answered. Yeah, so you are feeling better today, aren't you? What are you going to respond to that? Yes, I am. I'm okay. So a leading question is also very similar to well, a leading question is different from a closed question. A closed question is basically there's only a yes or no answer. A leading question is taking you to the answer that I want you to give me. Okay. And other distancing behaviors, false or premature reassurance. Don't worry, you're perfectly all right. Sab theek ho jayega. And this is also a way to quickly end the conversation on a positive note. We really don't want to get into the weeds about how difficult this conversation really is. Jollying along. Are, so what? You've lost so much weight. You're looking so nice. Or you're looking much better than you did. You're looking 10 years younger. Or making sort of jokes about the situation, trying to make it more lighthearted than it is, and encouraging the patient also to respond in that way. And a major distancing behavior is using jargon. So I use all my medical jargon. I throw it at you. I use words like metastasized, which of course now everybody knows what the word metastasize is, but I might use very, very complicated acronyms and words and things like that, because I feel safe using those kind of medical terms. And it also makes me, it props up my power in the equation. And after that, maybe some people are intimidated and they may not ask any further questions or whatever. We don't, as a culture, we don't have the habit of really questioning, senior healthcare workers, especially doctors. So these are other distancing behaviors. Please watch out for it, because if you find yourself doing these things, you could very well be distancing yourself from that conversation, which you're finding difficult. The thing to do here is to equip yourself with the skills of communication so you can have these difficult conversations. Okay, so what you can do, we've talked about all the problems, we've talked about what is difficult. Let's now talk about what you can do in the event that you are meeting a patient with a serious diagnosis, or you're going to have to break some sort of bad news. And please remember, like I said, bad news is not just about telling somebody they're about to die. Bad news also happens in what we call breakpoint conversations, when somebody has just lost mobility, somebody has lost a particular ability, the tests have come back which are not positive. All of those things are breakpoint conversations. Sorry, just give me a minute. All right. So is anybody in the group present today familiar with the spikes protocol? Have any of you come across the spikes protocol before? So if you have, you can just put your hand up, or you can, give me a thumbs up or whatever, because I just want to get a sense of how many people in this room are familiar with this. And that'll also give me a sense of, okay, so I'm assuming that spikes is new to everybody. All right, so this is actually, okay, Vinuta has come across it before, great. Barely heard about it, all right, okay. All right, so here is what the spikes protocol is. It is something that is used a lot, especially in palliative care settings. Spikes is an acronym. It stands for setting, perception, invitation, knowledge, emotions, strategy, and summary. And what does this mean? So firstly, when you go into a difficult conversation, make sure that the setting that you're in is correct. There is privacy, and you're able to give the patient your full attention. Don't try to have a conversation where you're breaking bad news in a busy space, where you're constantly being interrupted, where there is a lot of noise, all of those things. So setting is very, very important. Privacy is also important. Why is privacy important when you are delivering bad news? Why is privacy important when you're delivering bad news? Can anybody, use the chat box, or if you want to unmute and go ahead, please do that. Why is privacy so important?
Because they can have the freedom to react or respond the way they want, and not be embarrassed about it in front of others.
Yes.
Would that be, yeah.
Yeah, that's a very important point. Anyone else? Okay, I can see the chat box. Emotional outbursts. James seconds that. Emotional outbursts. Okay. Also, in terms of being and also being able to ask you questions that maybe it's difficult for them to ask in front of other people, right? So it's not just in terms of outbursts, it's also in terms of being able to ask questions, especially if it's 1 second. Yeah, so being able to ask questions that may not be easy questions to ask. And it's really important that it's a quiet place also, because you don't want this kind of conversation to be interrupted. Okay. Perception. First thing you do is assess how the patient perceives the medical situation. Don't go into it assuming that you know what the patient knows or doesn't know, or how far along the trajectory they're aware that they are, and so on and so forth. So you have to test their perception. You have to not test, but you have to elicit their perception. What do they know about their situation? Now I'm going to elaborate on that in just a minute. Invitation. Ask the patient how much information he or she wants. Please remember that it is not necessary that you give them all the information all at once. This is a difficult, this is a point that is a sticky point for a lot of people. How much information is too much information? How much information should we give? So I'm just going to stop for a second here and ask you, as people in this room, how much information should you be giving a patient? How much information do you think a patient should get?
Ma'am, I think entirely the patient should be aware of the problem.
Okay. Anybody else? I saw Vinuta unmute.
Yeah, first I feel we should find out how much they know, how much they are aware about the disease and prognosis, and then we can decide according to their situation. I mean, how they are taking it.
Okay.
Yeah. And over maybe in one setting, or maybe in over a next setting, we should disclose them truthfully. And then if they agree to tell to patient also, that should also be encouraged.
Okay. All right. So someone else has said what one discernible patient can actually receive. The patient can actually receive based on their own perception of what they are faced with. Okay. James, if you can be a little bit more specific about what you mean, that will be great.
Just trying to say that I think the patient would have understood like what he or she is going through, and according to one's emotional state, physical state, or maybe even try to break up the information to the extent to which the person can actually digest one's prognosis. I mean, you don't give the entire whole truth because you know it. You try to break it up so that the person receives it in a way in which he can grapple with his own reality or her reality.
Absolutely. We've all been told that every patient should get the truth, and at whatever cost, we have to be absolutely truthful with the patient. Very often in palliative care, we come across settings of collusion. Collusion, like I've said before, is when the family tells you, no, please don't tell the patient. Please don't tell the patient the whole truth because they can't take it. It'll take away their hope. It'll make her weak. She won't be able to cope with this disease if she knows the truth. So we basically are made to think that it's important that the person has to know the truth because only then the person can make decisions for themselves. While it is, do we really know everything about the patient? No, we don't know everything about the patient. I don't think we even really know everything about people who are not patients and even in other settings. But we need to be able to build a skill to gather, if not all the information about the patient, at least a sense of who they are, where they are, and how much information they want. So while the ultimate goal is hopefully to get them to say, please tell me everything I want to know, the process along the way is not that simple. And this is where the spikes protocol comes in. And I'm going to tell you how to use that because a patient might say, you know what, just tell my husband everything. And whatever my husband decides, I'm happy to do that, or tell my caregiver everything. There are some patients who say, yes, I want to know everything about my disease. But halfway through, they might change their mind. We're humans, we change our minds. Okay, so it's not, a person might have told you right at the beginning of your intake assessment, yes, as we go along, I want to know everything. I want to know everything as and when the test results come out. That doesn't mean that you barge into a conversation and just tell them everything, because the first time you met them, they said that they want to know everything. Every conversation, you have to check how much information they want from you in this particular moment. And like James said, their capacity for receiving the information might be affected by various factors, including their emotional state of being, their fatigue levels, the fact that they've had an argument in their family with somebody and they don't want to have this conversation right now in front of that person. Maybe there's a clash of treatment options. Maybe the family wants to push them to go and get something else done, but they really don't want to do it. So you don't know how that changes from minute to minute, meeting to meeting, appointment to appointment. So every single time you meet a patient, you need to check this one more time. Okay, so the invitation has to come from the patient of how much they want to know from you. And I'm going to take you through some specific scenarios to show you how to do just that. Okay, knowledge, provide information tailored to the individual. What do I mean by knowledge tailored to the individual? Provide information tailored to the individual. If I have somebody coming from rural, say for example, rural Chhattisgarh, coming to me, and over a period of time, we've had this conversation or whatever, but how do I have the conversation with this person regarding some very, serious, say changes in his or her condition, versus somebody who lives in the heart of, a metropolitan city, has access to different kinds of resources, the ability or the language, the ability to understand language is also different. How do I tailor the knowledge to the person that I'm talking to? Any examples? What if I'm talking to a child or a young person? What if I'm talking to an older person? What if I'm talking to a woman, an elderly woman? Any examples, any experiences? Or even any experiences when that was probably not done properly?
Smriti, I would like to share. Can I share?
Of course, please go ahead.
So, in my recent visit to Chhattisgarh, since you've mentioned about Chhattisgarh, so in Raipur district, like hospital, I met a person who's elderly person. I just wanted to interact and know what he, what is his feeling. So I started speaking in Hindi and I said, "आप कैसे हैं आज? आप कैसा लग रहा है?" So like just one question and then he said, "हाँ मैं ठीक हूँ." He's very happy with the fact that he's here because he had previous experience of not being properly looked at by whichever doctor he has met, and so after a lot of hassles he has come here, so he's very happy with the treatment going on. He started telling me his story. मेरे बेटे ने मुझे यहाँ लेके आया, अभी मुझे अच्छा लग रहा है, यहाँ पे सब नर्स अच्छे हैं. So like just the fact that he understood कोई मुझसे हिंदी में बात कर रहा है and simply she's asking me आप आज कैसे feel कर रहे, to start very simple conversation. So I think he was very comfortable with me and I spoke to him for about 20 minutes. Then I introduced myself. He wanted to know who I am, where I'm from and all that. So that's how I completed the conversation with him. Thank you.
Thanks, Ananda. Perfect. Thanks a lot. I can also see Abhijit use words or terms that are familiar to their worldview. Absolutely. Absolutely. Sunil, you want to say something?
Yeah, actually, ma'am, hello, am I audible?
Yes, you're clear.
Yeah, actually, I work in Jharkhand, but currently I am in Bihar. And I'm dealing with the community now. I'm doing actually, I'm making a proposal on non-communicable disease. So when we go to the community, actually, they see us as their boss. Okay. So, but as community development workers, facilitators, we need to reach to their level actually. Suppose when you go to the community, they will offer you a chair while they will sit on the ground.
Yeah.
But in that case, we need to go in this mentality that if they are offering you a chair and they are sitting on the ground, it is, as development facilitators, it is our responsibility to sit on the ground in order to get their level of understanding and in order to make the people get open to the discussions and all those things. So in order to get like a good information from the community, we need to go to their level only, to the ground level. It is not, it shouldn't be like a teacher and a boss or teacher and a student level. That's what I mean.
Thank you. I think that's beautifully put. And all of this actually has elements of things we talked about earlier: body posture, body position, and what we said, non-verbal cues, verbal cues, so on and so forth, talking to somebody with respect. Now, for example, an elderly person being referred to by their first name may not feel that sort of dignity or respect, right? Even if I'm a doctor, even if I'm a if I'm a healthcare worker or whatever, I might be the boss of this hospital. But if somebody elderly comes to me who needs to be addressed in a particular way, then I have to do that. I have to address them as in a way that they feel respected. But also what Abhijit said, you have to use terms and phrases that are familiar to them. And what Sunanda said, talk to them in a language that they understand. I can't talk to somebody who doesn't understand English and give them the bad news and expect them to understand what I'm saying. So I have to make the effort to have either a translator and make sure that I'm communicating my empathy through that translator as well. If I'm going to be talking to, say, a young person, I will again tailor it to the language that they're comfortable with. I need to use metaphors also that they can understand, right? I can't use a metaphor about, I don't know, I can't use an engineering metaphor with with somebody who's completely not even clued into how that works. So those kind of things, tailor the knowledge. And if it's a woman, there's cultural appropriateness in different kinds of communities, right? You're not going to hold the you're not going to hold the gaze of a woman who is culturally not comfortable with that sort of eye contact. or even when you employ touch. So I'll talk to you about that in just a minute as well. So tailor the information to the person that you're talking to, and provide information tailored to that individual. Also, what is essential for them to know. I've talked about the style of the communication, but the content is very important. Now, if I have done my psychosocial assessment correctly, if I have done all of those intake assessments correctly, if I've built that rapport and that trust, and I know what are the issues in the family and who is the decision maker, who talks to whom, I need to then tailor my communication in that way, because I need to be considerate about who is going to be making this decision in this family. So I will tailor my information accordingly. You need to tell your cousin or your uncle who is in Dubai, who is paying the bills, that this is why this particular intervention might be required. And it may come across as a little bit expensive, but in the long run, it might save you cost for 3 months. Because if the concern of that person's finances, I need to explain it in a way that my patient can go back and have that discussion at home as well. So I hope I'm making myself clear here. So it's not just the structure and the style, it's also the content of the communication. If I'm going to talk to the caregiver of a person who is a very stubborn patient, who is very non-compliant with their treatment, I need to give information to the caregiver that will help him make the patient more compliant. Okay, so I need to take all of those things into consideration. That is provided I know a little bit about the family history and the background, and I've actually paid attention to those things. Okay, so we've come down to knowledge. Emotions, respond with empathy. Again, not the easiest thing to do, because empathy is a tricky one, but I'll give you some examples of that. And finally, strategy and summary. When the patient is ready, present the treatment options and make decisions together. You have to invite them to be part of the decision making and the strategizing. And when you finally finish explaining everything, okay, this is the outcome, this is the interventions that are recommended, what do you think, etc., etc. At the end of the meeting, you have to summarize everything that has happened so that the person's retention is stronger. Okay, very often these conversations are left just up in the air, and people exit the conversation without really sort of going back to what was discussed, to also check whether they have understood everything as it has been intended. So spikes is setting, perception, invitation, knowledge, emotions, strategy, and summary. Now, putting this in action, let's talk about this gentleman. Would anyone like to read out this case narrative? Just unmute and start off.
Mohan, a 40-year-old man presenting with pain for a month and incessant vomiting for the last 2 weeks, comes to the OP. Recent investigations indicate malignancy. He has 2 children and are 8 and 10. He lives in a joint family with his brother's family. He has been asked to do CT scan, but cannot afford it, so he comes to you.
Go on. I think we've lost his.
Sorry. Worsening.
Can you please go back to? I think, was it only me or did everyone else also? Can you just go back? Yeah. So can you go back to his wife is anxious?
Okay. His wife is anxious but doesn't say much. His brother, who accompanies him, is upset that the patient is only worsening. He's also supporting the family financially. The patient asks you, "Am I dying? What is going to happen next? How much is the treatment going to cost? What are the possible issues concerning the patient and the family? And what are the challenges you are likely to face?"
Thank you. So let's look at this. Okay. I'm asking you to look at it from a communications point of view. You also look at it from the total pain point of view. And the patient has asked you, "Am I dying? What is going to happen next? How much is the treatment going to cost?" Think about the issues that have prompted these questions. Why would a patient ask you, "Am I dying?" Why would a patient ask you what is going to happen next? And why is the patient asking you how much the treatment is going to cost? Let's take each of those questions one by one. Sajan?
Because he is the only person supporting the family financially. So he understands that and wants to know if he's not there anymore, what is going to happen to his family. Or what is the course of treatment, how long it will take, how much cost it will be. So whether he can have food or he has to look for any other means, or who else can, he approach for help and so on.
Okay. Anyone else?
Ma'am, looking in the perspective of total pain, physically he is in a lot of pain, and that pain is contributing to his psychological distress where he's anxious. And if we see socioeconomically, he's the breadwinner of the family. And then there is a stress that brother is also not happy with what is going on. And this is going to affect them long term. And since he's the breadwinner of the family, he has to think about the long-term process. He has to think about what is going to happen once he's not part of the family.
Okay. Yes, thank you. Am I dying? He's asking because he wants to know upfront. He wants to be ready to face the worst. It could be that. Could there be another reason why he's asking, apart from also wondering about who's going to look after his family? Financial problems, dependence on brother, future of his children. Absolutely. No one likes to be dependent on extended family. Is there somebody you're noticing who hasn't said much?
Hello.
Yeah, please go on.
Yeah. I think your community involvement is important. If we can take care of his concern regarding family, children's education, food and all, that will take care of lots of his psychological issues. And so those are the challenges I think I will have if I am a treating physician.
Okay, so you're looking at the challenges part.
Yeah.
Okay, fine. Okay, possible issues. I see Rajiv saying suicidal thoughts. Yes, he could very well be having suicidal thoughts. He is not. Yes, please go ahead.
Those suicidal thoughts and those depressing things can be taken care if we can ensure regarding his family.
Good. Yeah, these are all possibilities.
Along with treating, of course, physical symptoms.
Absolutely. Yeah, so these are all possibilities. These are all trajectories that this whole thing can take. Financial insecurity, panic. He's not ready to face the fact he has very small children. Yes, he also has very small children. So great. I'm seeing that most people here have, are seeing beyond just the what we're reading in this panel. Now, what are the challenges you're likely to face? Vinuta has already talked about the challenges that she thinks, how do we connect them to communities so that they can take on some of these responsibilities and reduce some of his anxiety, possibly regarding the education of his children, regarding his financial dependence on his brother and so on. But tell me, what would you, if you were in this position where he's asked you any of these questions, I don't want you to tell me, I want you to think about how you would feel sitting in that chair if someone asks you this question. Please you don't have to reach for textbook answers. I want to know what you as an individual would feel. Do you feel equipped to answer a question like that?
Not
Smriti,
fully.
I would like to answer. Yeah, please go ahead, Sachin.
No, please go ahead. You go ahead, please. I already talked.
No, I just wanted to share that I have experienced that because I was asked this question by my younger brother. So, and I was really helpless. I didn't know how to answer. I wish I could know that time, like how to, deal with this question. So I just wanted to share. Yeah.
Thank you, Sunanda. Helpless, incompetent. Yeah.
One other thing I wanted to add is that, see, currently based on the initial what do you call test, only malign what do you call the basic part of that is only confirmed. The next step is CT scan only to confirm. So we have to, probably he needs assurance more, saying that don't come, don't worry, we'll go step by step. Don't come to any conclusion. There are lots of things to be done, so please be assured. So first thing is, because he didn't do CT scan is because of lack of money. So let's address one by one part of that, and then do the required seek the help and support to get that done first, and then based on the outcome of that, let's talk to him further. Maybe could be another approach.
Okay, that could be another approach. Yeah. Very honest response from James. I don't think I'd be able to process those questions up front. Now, if I first console, adopt the children, let's back up from adopting the children. We're not even close to that yet. We don't know if he's dying. He's just got a malignancy. Okay. We don't know how long he's going to live. Let me just put it this way. Like, if I ask you right now, I've come back to you with this malignancy and I've been asked to do a CT scan, and I just say to you your name, whatever, how much time do I have? How many of you are comfortable answering that question? Or, so even the question about how much it's going to cost, how much is it going to cost? Do you really know the answer to that? So how do you have this conversation without completely deflecting it or giving, I would even say, premature reassurance? So we can never tell about the time left. We can't, but I think you'll have a session with Manisha. There is a session with Roop Gursahani, isn't there?
Yes, ma'am. We do have.
So Roop will talk to you about prognostication and having a conversation about those kind of things. So sometimes there is a way to tell how much time someone has, not down to the minute and day, but you have a ballpark idea. And I'm going to let Roop talk to you about that. Okay, so now coming back to this presentation, right. Firstly, let's go back to, I'm going to elaborate on the spikes protocol a little bit, taking specific elements, and I'm going to give you some tips on what those sections can look like. Okay. Very important. First of all, please introduce yourself by name and by role. How many times have you walked into a healthcare setting and you have no clue who is talking to you? I mean, you might know that they're a doctor or if it's a senior doctor, you know exactly who is the attending physician and stuff. But otherwise, even then, there is a tendency for the doctor to assume that you know who I am. Why do I have to introduce myself? Right? But isn't it a little bit more humanizing to come and say, hi, I'm so-and-so. You're coming to my class. You know the faculty name is there, but I will still say, hi, I'm Smriti. Not for any other reason, but simply because it just instantly, it puts us on an equal footing where I also introduce myself. I've seen this happen over and over and over and over again in palliative care settings where the caregiver is asked their name. And do you know how shocking it is for a lot of caregivers to be asked their name because they have never been asked their name before? So by asking for each other's names and by introducing yourself, you are instantly humanizing the interaction. It is no longer a doctor and a patient. It is two people who know each other's names. So whether you know it or not, and if you've been in conversation with somebody and you've heard them, take your name. They first of all asked what your name is. They've remembered it, and they're actually addressing you by it. Do you not feel a little bit more comfortable about it? Sorry, that's a leading question. But how do you feel about somebody, using your name while talking to you? It makes you a lot more comfortable with them. Okay, so point number one, ensure comfort. How do you ensure comfort right off the bat? Introduce yourself. Address the patient by name, and please find out the caregiver's name. It makes your patient feel like you are also invested in the family. It also shows, it demonstrates that you care about the family as a unit, because you also care about someone beyond the file name and the person who's on the front lines of looking after somebody. Okay. Assess emotional state. Simple. How are you feeling? How are you feeling right now? You've been in and out of hospitals for the last few months. Right now, tell me how you're feeling. Given the situation, if you don't want to get into the feeling state, the cognitive thing to say is, given the situation, what are you thinking about right now? The situation could be anything, yeah? You have to substitute that. So given the fact that you've been asked to do so many tests, and that you've shifted hospitals, etc., what are you thinking about right now? These are open-ended questions, and the person is likely to tell you, I'm a little bit anxious. I'm scared. It could be many things. You might even have someone tell you, I'm really happy to be in your care. So you can get different kinds of responses to this question. So assess emotional state. You'll sense there's levels of anxiety, there are levels of comfort, all of those things. Also, it goes a step further in ensuring a sense of safety with you as well. Okay. Listen to concerns. Active listening, both verbal and non-verbal. See the body language. If someone is saying, yeah, I'm fine, I'm okay. But am I okay? You can't see much of me on Zoom, but if I'm constantly wringing my hands and I'm pressing my hands together, or I'm like fidgety or whatever, I'm not okay. Okay. Tone of voice, attention, gestures, words, nodding, whether they're responding to you, all of those things. Please pay attention to all of these little cues. There is something called generous listening, which is also just to listen with generosity. And that is a cultivated practice. So as therapists, as psychologists, we're constantly taught about active listening. But sometimes what happens with active listening is that, there's always parallel processing going on. Parallel processing is happening. Why did she say this? Why did they not say this? Why did they? Sometimes in all of that parallel processing, you are missing what is happening in front of you. So I would say, maybe slightly controversially, my professors may not be very happy with me right now, but more important than active listening is generous listening. Listen with generosity, the attention and the active listening part will automatically come in. Okay. Reassure, but in realistic ways. Okay. Don't reassure by saying everything is going to be fine. You don't know that. What you can reassure them is of your continued support and professionalism with them. So we will do everything we can to help you. We will do our best to take care of you. You are not alone. We are there for you. We will talk to your family regularly. These are the kind of things you can reassure them on. These are safe things. These are things you can deliver on. And it is by no means giving them the false assurance that, everything is going to be fine, don't worry. And be careful not to overpromise or provide false reassurance. Sorry, 1 second. My apologies. So be careful not to overpromise. Can you give me an example of an overpromise? Anybody? What is an example of an overpromise?
Everything will be okay, don't worry.
That is
You will
false
be all right within.
reassurance. That's a false reassurance.
Yeah.
You will
Go
be
ahead,
all
ma'am.
right. No, please, Srinivas.
Yeah, giving them a time framed kind of thing. Within 2 months, you will be all right, or within 1 month, I'll make you walk, and giving those kind of thing. That is like over promising actually. Giving them a time frame, then saying that by next week you will be out of the bed and running and jumping. So that's kind of thing.
Absolutely, thank you. Yes. Other examples?
Hello.
Yes, please, Sunil.
Maybe like when we use the term we know, like when we go to the community as an organization, when we say we know, that becomes more of like promising them. So when the first person stands, no, there's a big question in that. That's what I feel. The term we is very, what to say, dangerous in community development or in terms of dealing with the community who are vulnerable. That's what I feel.
Okay, I can understand what you're saying here. And this is an important point. Promise what you as an individual having this conversation right now can give. Pallium India is going to make sure that your family is well taken care. I cannot make that promise on behalf of my entire organization and every team member when my team members are not present. What I can say is, from what I understand, this is what we can do. Let me have a conversation with my teammates and see what else we can do for you. Right? So that sort of a thing is also very important. Over-promising, other examples could be, 1 second, hang on. Okay, James, I'm going to come back to this sort of cross dialogue just after we finish this section also. All right, I don't want to get into a loop about that, but we are going to come back to that. So, I lost my train of thought. So yeah, so over-promising can also be things like, you can call me anytime. I'll come and visit you every week. I can't. There is no way I can visit this person every week or say, call me anytime. I can't take their call anytime. I need to say, you can call me on Thursdays and Fridays I'm usually free between noon and 4 o'clock. And, if you want to have a conversation, please call me at that point and we can talk. Parmeshwar, you want to say something? No? Okay. So over-promising and false assurance can happen in many different ways. And these are just some of the ways in which we tend to do this, usually in an attempt to make the person feel better, or our comfort level is a little fluctuating at the moment. Okay, now very quickly, I'm going to take James's question to Sunil, because I think maybe we can have that discussion very quickly. Let's give it like 4 or 5 minutes. So the question, James, do you want to articulate it again?
Sorry, what I couldn't quite understand what Sunil meant actually. So I was just looking for a clarification as to what he was trying to say when he was saying that, when he's using the word we, how is it using in the collective sense as being a community who can't really sustain the person or can't really help the person? I couldn't really quite figure out.
Sometimes when we go to the community, we have this communication gap, like as ma'am just after the point only she think, like when we promise the community, we actually we should have the whole team with us, because when we go to the community as individuals, sometimes we go with our perception, and we many a times we go with different mindset to the community, because we are overloaded with the organization work or the responsibility we already have. So in community, when we go to the community, we like try to interact to the community in the point of view of the organization. So in that case, many times we use the term हम ये करेंगे, हम ऐसे करवाएंगे, हम इससे मिलवाएंगे. All these things, it becomes a very danger in the later stage. So that's what ma'am clarified is that when we go to the community, it should be clear when we promise anything to the team, to the community, it should be the team should be present there. That was an apt reply to what I pointed.
Thank you, Sunil. James, okay?
Yes, yes.
Just one question and thought also on that, what Sunil mentioned is that brings the question in the sense, is the team not working together? Are they not on the same page of, working as a team? Like, is there a disconnect? Is there a miscommunication and so on? So it is, I think that calls to the need for Pallium India, for example, or any, hospital caregiving or whatever center to have, a periodic, whatever that thing is, that maybe on a daily basis, that how our approach should be, if there is a special case for that day, any critical patient, how are we going to address as a team together? So personally, I feel that, instead of saying I think it is better that we say we, but at the same time, at the back end, work together to make sure that it is, don't promise, over promise anything. I'm not saying any false promises, but assuring that we are working as a team, not that I'm working in isolation and somebody else comes and tells something else, it should not be a mismatch of anywhere. So that part has to be taken care by the center, the treating center.
Fantastic. So that's actually very, very well put. And I would, yes, please, Sunil.
Yeah, actually, I don't work in a clinical setup, so my response will be more of community approach. So
Yeah.
what sir said, like he meant in a clinical level, but as community approach, see, sometimes we go to the community as individuals also, because we are
Yes.
targeted with specific villages and all those things. So yeah, it should be clear before we go to the community and promise anything to them. We should know the protocol of the organization, what we ought to say to the community and all those things. The line of communication should be taken control. That's what I meant.
So see, this is also really interesting for me that in different settings, how an individual represents the team or the organization as well, right? So Sajan, you're absolutely right. In the multidisciplinary team, ideally, you should have had that conversation before you meet the patient. And in fact, you decide which one of you is actually the most appropriate person to meet the patient with bad news. It may not be the doctor. It might be the nurse. It may, in some cases, be a social worker. Right, it could be anybody. So also, who has the biggest rapport with the family? Maybe that is the right person to go and meet the person, the patient. But having said that, it's also really important to not overpromise on behalf of the team. Even in the doctor will call you tomorrow. I need to know if the doctor has the time and space to do that as well, right? So because what happens is, and I'm sure some of our social workers will also bear out this fact, the patient and the family then starts calling the social worker and telling them that I was expecting a call, it didn't come, what's going on? So those kind of things. So there's an element of cohesion, like you said, the team has to have each other's back, and at no point a spokesperson for the team who doesn't know what the team's capacity is. That's one. And in other settings, of course, it is always important to remember that there are certain decisions that you will be surprised by some of the questions that are asked. You will be asked to make a decision or help the patient make a decision in that moment, at which point it's okay to say, let me get back to you after talking to the rest of my team, because I may not have all the answers. I don't want to be inaccurate in my response to you. Okay, so if we can just is this okay? Can we move on from here? All right. Okay. So be careful not to overpromise or provide false reassurance. Assess the need for information. Find out what the patient already knows. What do you know about what you're experiencing? Find out what the patient wants to know. What is it that you would like to know more about? Find out if the patient wants to know more. And here, a safe way to broach this subject is to say, is there someone else you would like me to discuss the treatment plan with, or do you want to talk to me alone? This is one way of assessing how much information the patient is ready for. they might answer saying, I think I'll just wait for my brother to get in because he's usually good at understanding these medical terms and I want him to be here. Which is telling you the patient doesn't want this information right now in this moment by themselves. Or you say, this also tells you if there's conflict in the family and if they would rather have this information beforehand. You know what, it's better you tell me now because the minute my mother comes into the picture, she gets all anxious and stuff. She doesn't want me to know things. So yes, I prefer you tell me now. We can always have a discussion later with my family if that's the case. So you'll have different responses to it, but it'll give you a sense of how much the patient wants to know and where they are emotionally with this kind of news. And this is a very important, give a warning shot. Giving a warning shot to assess if the patient is ready to know more. So a warning shot is a sentence like this. Things are not improving as we quite hoped. Would you like to know more? Another example of it is the test results are not exactly what we hoped they would be. So any other warning shots you can think of? I want you to think about this now. What are some ways in which you can give a warning shot?
Ma'am, can you repeat the warning shot, please, once again?
So one of the warning shots is the test results aren't as good as we were hoping they were. Would you like to know more? Anything else? Can you think of other warning shots? What is it going to elicit if I ask you that question? What are some of the responses you can give me if I tell you, the test results weren't what we exactly hoped for? Would you like to know anything more about it? Or do you want me to wait till, your caregiver is with you? What do you think what kind of response do you think it's going to elicit in the person if I give you that warning shot? What does it do for you?
It gives us an opportunity to access patient's affect. Maybe sometimes they won't speak, but the patient will process the information. And if some people react in different ways, so we'll have at least some time to see if the response is going to be yes or no, just by seeing how they are going to respond.
Okay. Yes. Anyone else?
Or they may react like whether it is very serious or whether it can be managed. So that would be my first question.
Anything else? What does it give you time to do? It gives you time to process your emotion. It gives us time as clinicians to assess their emotional state as well, yes. But it gives you a sense of what's coming next is serious. Now, do I want this information right now when I'm alone? Or do I want it when I'm with somebody? Or do I want it at all? You know what, just talk to my brother about this. So your warning shot, in my opinion, that warning shot is one of the most important skills to learn in delivering bad news. Okay, and an important thing to remember is that if a patient says not right now, you have to respect it. You can't force beyond that point. Okay. Deliver information with empathy. Empathy is such a word, my God, it's but anyway, how do we exercise empathy? Use the patient's primary language if possible. If you know Hindi, if you know Marathi, if you know Bengali, if you know the language that the person speaks, use that language. If that is not possible, get somebody to translate. I know that's not always possible either. But in which case, use short sentences. Why should we use short sentences when we're giving bad news? Why do we need to use short sentences when we're delivering bad news?
For them to understand and process it as much as they can.
Yeah.
Yeah, I think Sajan, I think the second Sajan.
Okay, all right. Avoid medical jargon, for obvious reasons. You know, your tumor has metastasized to your this zone. This they don't know. You're giving them bad news. Have the courtesy to give them bad news in a way that they understand what is exactly going on, and they don't have to constantly ask you at a very difficult time in their lives to please clarify, please clarify, please clarify. Be as clear as possible, because you're doing them a great service by not putting him in that embarrassing spot of also thinking, oh God, he must be thinking I'm so stupid. That's the last thing that you need to make your patient feel at a time when you're giving them probably some of the worst news in their life. Okay. State issues relevant to the patient honestly and clearly. I'm going to repeat that sentence. State issues relevant to the patient. What is relevant to the patient? Here is what we need to be prepared for. Here is what we are doing for this condition. Okay, now I also want to take a minute here to emphasize that giving information that is relevant to the patient means you have had to do a good psychosocial assessment. Without good psychosocial assessment, you cannot be sure of what information is relevant. This is what you need to be prepared for. You need to be prepared for one of your daughters coming and spending 3 months in Bangalore with you. We need to have somebody with you full time. Either it's one of your children, or you need to get help from outside. Is that possible for you? No, I cannot afford to keep a nurse at home. Then is there someone in your family who can come and take it in turns to be with you at this time? Because that is what we need to be prepared for. So you're inviting them already into a shared decision-making process, right? And this is information that is relevant to them. I'm afraid this means that for the next 3 weeks, you need complete bed rest. Do you have help at home for someone to come and cook for you? Okay, you need to get yourself a water bed, an air bed, so that we want to prevent pressure sores. Now, when you're talking to a caregiver, you also need to be helping them prepare. Now, how many cases do you know where a married daughter has had to then split her time between her own family and her kids and coming back and looking after an ailing parent? What are some of the things that she has to do in order to make that possible, right? There could be so many different things. Someone has to switch cities. Someone has to quit their job. Somebody has to take time off from work. So all of these negotiations, there are multiple negotiations happening in order for this to happen. And that's what you need to know about a family in psychosocial context before you can give them the information that they need at this point. Now, this is what your test results have shown. This is what it means in terms of your disease, but this is also what it means in terms of what preparation we need to make. So if we start the next cycle of chemo, which we should start soon, you are likely to feel very fatigued on day 3 or day 2. So we can postpone doing chemo till one of your relatives comes and starts staying with you. Is that possible? Am I making myself clear? Are you all following me? Yeah. So that's the kind of way in which you can help them prepare for their own care management. And that is empathy, because you're empathizing with their life situation. Again, in order to do that, you need to know their psychosocial history. Okay. Coming back to the slides. Okay. And empathetic in your language means saying things like, I'm sorry, I know you were hoping for better news. I can only imagine. Please don't say, I know how this feels. That is not an empathetic statement. That is, in my opinion, a ridiculous statement. Nobody knows exactly how anybody else feels. I think we need to discard that sentence from our vocabularies. We can only imagine, because that's a fact. 2 of us might have had, similar circumstances. Like there might be someone else in this room who has lost her mother at the same age that I did, which was as a teenager or whatever. Even then, our experiences are not the same. So please don't say, I know how you feel. Say, I can only imagine how difficult this must be for you. Okay, so this is how we are empathetic in our language. And explore emotions and provide support. Now, after you have delivered the bad news, what is going through your mind, or even before, not even after you've delivered? Suppose you've given a warning shot, or at any point in the conversation, you can pause and actually check in to see how they are doing emotionally. What is going through your mind right now? What is your biggest concern at the moment? You will be amazed at the answers you get for that question. Not everybody is worried about dying. Not everybody is afraid of pain. Their biggest concern will be, God, I can't send my child back to school. For somebody, their biggest concern might be not having enough money to have 3 meals a day. For somebody, it might be, God, that means hospital admissions. How can I leave my child alone with the maid at home? You can get 100,000 different concerns. So that's a very important question. What is your biggest concern at the moment? Is there anyone in your family you would like us to talk to? Is there anyone in the community you would like us to reach out to? And of course, that sentence can change depending on what you know about the family and the eco map and all of those things. Okay, these are good sentences to use. Now, I'm just going to come back because I think this is important. I think like Sunil said, sometimes they pull up a chair or whatever else. Body position when you're having all this conversation is very important. Either you both sit or you both stand. Don't one person sit and one person stand. Either way, it doesn't work. If somebody is bedridden, sit down on a stool or a chair and try and be at level with the patient. Okay. Body posture, a positive leaning forward, not hovering over the patient, but leaning forward to show that you're interested. Don't arms crossed is very, it gives off a very negative feeling. Or, just sitting with hand on the head or sitting like this. These are all negative. Okay, so, and this is stuff that all of you know intuitively. So I'm not going to spend a lot of time on this. So please be aware of your body posture. Please be aware of your body position. And touch can be a very therapeutic tool if it is correctly employed. As a therapist, I was told when I was being trained, you never touch the person. Have a box of tissues handy, pass it on if the person cries, never touch that person. I'm very pleased to say that palliative care has helped me unlearn that that particular trait, because I'm not saying go and hug everybody. That's completely inappropriate, but it's really important to know that sometimes touch does make a difference. And there are what we call safe zones, the back of somebody's hand, somebody's shoulder, the knee. These are safe zones, the neutral zones. It's absolutely fine. Okay, read the room, know your audience. I mean, know your patient and know when it's okay. Avoid, with children, I see this happening a lot where they get patted on the head. No patting on the head for anybody, not even children, not anyone. Okay, so, but touch is very, very, very powerful. It can be an extremely therapeutic thing. And I'm of that camp that believes that it has to be moderately employed. And in fact, it actually goes a long way in establishing that rapport and that bond and things like that. So touch is something that we don't dismiss out of hand. And we certainly don't think that it's not useful. It is therapeutic if used correctly. Open-ended questions. Ask questions that allow the patient to respond in a manner that they choose, unlike leading questions, which leads you to an answer that I want, or a closed question. Now, I'll give you examples of both. An open-ended question. What aspect of the future worries you? Somebody's angry. Can you tell me a little bit more about your anger? Why are you angry at this point? Tell me about your current problems. Okay. How are you feeling today instead of feeling fine? Huh? So these are open questions, which allows the person to give you a much longer answer in a way that they think is correct. Also, open-ended questions requires your investment of time. Imagine if the person starts answering and then you have to go somewhere else. So also know when to employ the open-ended questions. Examples of closed-ended questions. I want you to answer this in your heads, okay? Or even out loud in the chat box or however. Do you have pain? How can you answer that question? In two ways, right? Yes, no. Sorry. Where is the pain? Where is the pain? You'll say in your foot, in your head, in your ear, whatever. Is it continuous? Srinivas, did you want to say something? Okay, fine. Is it continuous? Again, yes or no? Yes, it's continuous. Do you vomit soon after food? Yes, no. Do you feel breathless even at rest? Yes, no. So you see, these are questions that will only have one of two answers. I am not giving the person maneuvering room. I'm not saying, when does your nausea usually affect you? I don't say, describe your pain for me. If I say to you, and I'm just going to pick somebody who I can see right now, Sajjan, if I have to say to you, describe your pain to me, what am I allowing you to respond as?
That is definitely an open-ended question, and then so that I can be more open in terms of addressing like how much is the pain, where it is it continuous, or is it moment based, whatever, so it is basically an open-ended. So the patient, in that case tends to answer more and then gives you more information rather than yes or no.
Okay, so if anybody else, if you can unmute, you can share with me. If I ask you, you all experienced pain at some point in your lives, I'm assuming. If I ask you to describe the last time you experienced pain, what kind of pain was it? Describe it for me. Would any of you like to try?
I would, ma'am. So
yes,
I
Manoj.
had a migraine last yesterday morning. I had migraine, and it continues till this morning. I'm better now, but with that pain, I couldn't concentrate on my work. I couldn't cook on time. I just wanted to sleep. I didn't want to interact to anybody else. It affected me so much that I was not willing to answer my phone, the messages, anything and everything which was part of my schedule was affected because of that pain.
Okay, thank you. So
just to add, sorry, just to add, if somebody is aware of the scale of pain, that term, and then they can explain it in terms of number, we can ask that. Or if they are not aware, maybe we can write it on a paper, like a line, less pain and more pain, and then you can ask them where it is your pain, something like that.
Yeah. So we have the pain scale, and we also employ facial expressions for those who are not really comfortable telling you on a number. So Manat's response tells me more than just about her pain, right? What else does it tell me? What else does it tell me? It tells me that she cooks. It tells me that her role in the household is quite important. She likes to she likes to be, in communication and use her phone. She's not able to. So by asking her describe your pain, she's also told me what her pain stops her from doing, which tells me what is part of her day-to-day life. Versus, hey Manat, your pain is continuous.
Yes.
That's it. Doesn't tell me about anything else in her life. So these open-ended questions, this is the purpose that they serve, right? It tells you far more than just about the symptom. It tells you about the person. And if I were to ask somebody about breathlessness and things like that, it tells me a lot more. So each of these questions about symptoms can actually tell you a lot more. And palliative care is about that. It's looking beyond the disease to the person. Okay. Active listening requires you to listen. It requires you to give verbal and non-verbal feedback to show signs of listening. It's not enough that you're listening. You have to actually show that you're listening. Nodding, eye contact, leaning in. Mirroring. What is mirroring? Mirroring is mirroring the body language of the person in front of you. It takes practice, but over a period of time, it comes quite naturally. So if somebody is leaning forward, you lean forward. If somebody is, got the head tilted, that, whatever, those kind of things. Asking questions, that tells the person that I'm interested in knowing more about them. Asking open-ended questions. Reflecting back what is said. So from what you told me, it makes me think that, Manat, it sounds like you lost a whole day to that migraine. And a lot of the tasks that you would normally do, you weren't able to do. So that sounds like that was debilitating pain. I'm reflecting on what Manat has said. In some cases, I could also paraphrase and say, so from what you told me, it sounds like basically you couldn't carry out any task, and that's how debilitating the pain was. Reflecting brings in a little bit of emotion into it, where I say, God, that sounds like a very distressing 24 hours. Asking for clarification. If I have not understood something, asking for clarification is very important. And finally, at the end of our conversation, summarizing the whole thing. When you came here, you looked a little bit anxious. And then we talked about this. This is what you told me in response to this question that I asked you. From that, I understand that, things could be made a little bit better if we managed your pain better, or maybe the medication is not working as well as we thought it would. So what we have decided to do now is to up the dose, and let's see where the new dose takes us, and if you have a better time with this current dosage. That's me summarizing a hypothetical conversation with somebody. So summarizing it also basically reinstates what was discussed, what decisions were made, and also it might give your patient and their family a chance to say, hey, no, but I'm not actually comfortable with it. Can we try something else? So that final adjustment can also take place once we summarize. Like I said, empathy, you can be empathetic in your language. I can see how upsetting this is for you. I can see how hard this is for you. I feel that you're quite angry today. These are empathetic statements where you're just sort of acknowledging the person's, distress and showing them that you acknowledge it and that you understand it. Not saying, I feel your pain. No, I can see that you're in pain and that this is very upsetting for you. If you are feeling their pain, you're not in the right place, because you are here to help them problem solve, not to feel their pain in that sense. Okay, you're here to understand their pain and help them find a way out of it. Okay. Benefits of empathetic communication. As you can imagine, there are several benefits. Firstly, by giving correct information, you are removing uncertainty, and a lot of distress for a lot of families comes from uncertainty and lack of information. So by giving them the correct information, patients and families cope better because they know what to expect. They know that you're in their corner, you're going to give them honest information. And a lot of the anxiety a person might be feeling might come from an imagined source of distress. If I don't give you the full picture, and those of you who are trained as therapists and psychologists here, you know of the Gestalt school, which the human mind has a tendency to fill in gaps in information. If I give you half information, you will fill the gaps with your own imagination or with your own experience or whatever it might be, which may not be accurate, which might be much worse. So it's important to remove uncertainty. Patient and family can make informed choices if you give them the right information with that shared decision-making element. It prevents unrealistic hope and loss of scarce resources. If I tell you, sab theek ho jayega, just we'll do everything, every intervention there is for this disease, we're going to try everything. At the end of it, we're going to beat it. I am basically not doing that wallet biopsy. I'm saying that as long as you keep trying, there's a chance you can beat this, even when things are futile. A person might be down to their last bit of finances. And by giving them false hope that they can beat it if they keep trying, what we're forcing them to do is also dip into those very scarce resources that they have. At the end of the day, patient doesn't make it, family is impoverished, and there's a whole bunch of other problems. Okay. It gives opportunity to express emotions, something that we really need. We need to humanize healthcare in that regard. And it leads to better compliance. This is a big one. If the patient and the family trust you, and they have that rapport with you, they can trust you to give them reliable, good information in a timely way, that you're empathetic with them, you understand their situation, they are likely to comply with the treatment option that you prescribe or that your team prescribes. And that is really important. So I'm going to let you take this home. We talked about, and I will share this slide with you. So we talked about ensuring comfort, assessing emotional state, listen to the concerns of the person, reassuring them, assessing their need for information, delivering information with empathy, and explore emotions and provide support. This is the slide I'm going to send back with you. It's Mohan. And now that you've gone through all of these different steps with me, the spikes protocol and all of these steps, I want you to actually revisit this family and do these steps with them. You can pick different people in the family that you want to do this with, or you can pick Mohan or however it is. But I want you to start from the beginning and work all the way down to exploring emotions and providing support. If any of you find that you're getting stuck at a particular point, we can always talk about that. Okay. All right. And in the last few minutes that we have, I'm going to also talk to you about anger, because it's one of the most difficult emotions that we can encounter in a clinical setting. Now, when the patient or the family is angry, and they could be angry for many reasons. They could be angry because you asked them to come at 2 o'clock and you were only able to see them at 2:30. They could be angry because the patient's pain is not better. They could be angry because of the way they've been treated in the past by the healthcare system. They could be angry because they think that you are prioritizing another patient over them, or you're not giving them the best intervention, whatever. It could be many reasons. It could be that they didn't like the way the nurse spoke to them, or the fact that it was the nurse who spoke to them and not the doctor. So anyway, it could be 100 different reasons. Firstly, make time and space and listen. Very importantly, neither accept the blame nor rush in to justify. This will only escalate the issue. If you say, okay, I'm sorry, that won't happen again. You do that with the intention of closing it and saying, at least I'm being humble and I'm apologizing, but no. It actually opens the door for even more anger later. Or so you don't have to quickly accept the blame or rush in to justify. No, but the reason that happened was because, the doctor was not here, so the nurse was the only person and we didn't want to keep. The more you try to explain, the more irritated the person will get. Try and invite them to a private space. I'd really like to talk to you some more about this. I can see that you're angry. Do you mind if we just go into this room? And I want to listen to everything that you have to say. Encourage the person to sit down. This does two things. And this is not a joke. It's actually a less challenging position when you're sitting. It's harder to hit when you're sitting. Also, okay, it's a fact. And it's and this is something that we all need to be careful of in today's scenario, right? It happens, so don't think it won't happen. But invite the person to sit down, look beyond. And what it does is, in this time of inviting someone into a private space, getting them to sit down, they might release some of this tension also. It also gives you time to regroup in your head. Look beyond the anger to the fear, to the grief, to the concern. Always, always, always behind anger is one of these things. They're either afraid that they're not getting the best treatment. They're either really scared that they're going to lose this person. They are either really, really grieving over what's happening right now. They know they're going to lose the person in a while. So look beyond it. Try and understand where they're coming from. Yes, there are people who will just come and be entitled because they think they can. Okay, so I'm not saying that not everybody is not always operating from fear and grief. And some of them are just entitled. I'm the MLA's son, so therefore I should get treatment. And if you don't get it to me, it's more of an ego issue. But there also there's a reason why he's in a healthcare setting, right? Because somebody he knows is sick. Okay, maintain body language that conveys receptivity. So don't look at the file or don't look at the door or whatever. Just show that you are listening to them. Be mindful of eye contact, not coming across as a challenge. That's another important one. and promise to investigate any unresolved issues and to talk again. You know, I've heard what you said, and you're upset about the fact that the nurse said this. Let me just talk to her. And so this is important. Don't say, I apologize on her behalf. No, you are undermining your teammate if you do that. Instead, say, let me just understand what her side of the story is, and I'm definitely going to come back and talk to you, and let's resolve this together. Promise to talk again, and talk again. Don't say we'll talk again and then never call them back, because that's going to really upset them again, and then you're going to have a bigger group waiting for you in your clinic. Okay. So this is what happens. These are some tips for when a family is angry. And when you are angry, don't forget that you are also human. Buy time to bring your own emotions under control. So the person says something to you that really like flips you out because it's unfair, it's unjust, it's untrue, whatever it is. But by getting that person to come and sit down, getting yourself a glass of water, you're also emotion. I'm so worried that, you know, I'm going to get fired from my job or whatever it is. Understand that as well. Cohesion within the team. This is really important. If you are, there's a point two steps below. If you are doubtful of regulating your emotions, it's preferable to get someone else to handle the situation. It's okay. It's better you hand it over to somebody else, not by means of deflecting, but because if you handle the situation right now, it's only probably going to get worse. Either you get somebody else in the room, but in order for you to be able to do that, you have to have that team cohesion that you have to build, where your team can do this for you. And don't expect issue to be resolved with one meeting, and definitely have a debrief with your team later. Sit down and say, gosh, let's talk about this patient who came in or the family who came in and how we were able to handle it, what worked, what didn't work, maybe what we should do next time. And so that sort of also builds team cohesion to a large extent. Okay. And yes, Abhijit?
Ma'am, I was just seeing that some of these parts are about protecting yourself in terms of the reaction that can come from the patient or his family. But what if there's a case opposite about you get more involved emotionally and all that? So, or perhaps you're more over concerned about it. So what is the one thing you tell yourself that, you know, when you're handling a case, because there has to be some kind of a holding back, right? In terms of when you do handle a case like this.
If you find that you're feeling emotional about it, that's enough of a cue for you to take a step back. Why am I getting emotional about this? Why am I? So in psychology, we call it transference and countertransference, right? So countertransference is when I'm projecting back on the person in front of me. Now, if I'm starting to get emotional, I think all of us know when our emotions are acting up. Which is why you have, you know, that getting a glass of water, sitting down and all of that is just not to kill time. It's actually to check in with yourself as much as to allow that person to calm down. Those are small little rituals, but that will actually de-escalate. You have to be mindful. But there are people, of course, who are so invested. Nay, I want to talk to this family because I took care of this patient. It's my responsibility. It's my duty to sort this out. Please let me do it. I made the mistake. Then other team members need to step in and say, yes, you looked after this family, but perhaps right now in this moment, you know, you need to also check in with yourself. Let us handle the first round and we'll call you in when they are calmer and you're calm. So that kind of conversation can also happen. This is why your teammates are so important at this point, because it's the team that's taking the blow, not that one person. Yeah. Detached attachment, very Buddhist. Okay, finally, sometimes unfocused anger or fear converted into anger may come at you. Okay, the best way to deal with this is to listen without interruption. Don't interrupt to try and justify constantly. By the time they finish, their anger will start to reduce. If you listen to somebody, of course, if it's a ramble, you may need to come in, but usually that energy that is blowing up because somebody's angry, and you know, very often when you're in a challenging situation, when someone is angry, they say something provocative and they're waiting for you to say something back, right? And you feel the need to say something. But if you stay quiet and say, tell me more, I'd like to hear more of what you've just said. I can see that you're really angry right now. Help me understand what's making you so angry. And they'll keep talking, and it'll diffuse, it fuses out. Okay. Some patients become uncommunicative and withdraw. Consider why. If somebody is not talking to you, it's maybe not because they're angry, but because they're exhausted. So don't assume that it's always anger. Caregivers often feel guilty, inadequate, helpless. I can't tell you how important this is in general communication, where you go to the caregiver and say, you know what, you were put in a position where you had to take some very hard decisions. And given the situation and everything that was going around, you did your best. I know you did your best. That simple sentence from someone who's a professional to a caregiver really goes a long way. I cannot overemphasize it. Because very often caregivers are feeling like, I'm not doing enough, nothing I'm doing is helping, and she's always angry. So when somebody from the healthcare team goes and acknowledges to a caregiver, listen, you're doing your best. And had I been in your position, I would probably do the same thing. Stuff like that, but just to acknowledge that. So it takes away some of the guilt. They might tell you, yeah, but my father thinks I'm not doing enough. He thinks I'm just being argumentative, this, that. Yes, but in being argumentative, you're just looking for the right solutions. I think that's what you're doing. So, I can see that you're trying to find the right solutions, and that might be seen as argumentative, but you just want him to get better. So I can see that you're doing that. So those kind of sentences really go a long way. And that also builds rapport and trust between you and the caregivers as well. Yeah, take care of yourself as well. Yeah. And avoid making commitments to relieve momentary distress. I've said this. Make only those promises or commitments that are realistic and within your capacity to deliver. And hope should always be realistic. It should not be unrealistic hope. This doesn't mean you have to say, oh no, you're going to die. It's not that. It's the fact that, yes, there are going to be some tough days ahead, but I can assure you that we will be with you every step of the way. There are ways to relieve your pain. There are ways to relieve this kind of distress. We're working on it. We're going to do everything we can to make sure that, your pain is under control, things like that. And so if sometimes unfocused anger happens, be ready. It's going to happen somewhere in your career, somewhere in your experience. You are going to be subjected to someone's anger. The best way to deal with anger is to listen without interruption. So listening is key. Some patients are reasons think that they're angry. Caregiver. I know we're running out of time. We've run out of time, but just to frame this, bad news is, for example, when somebody starts physiotherapy, he's had a bad stroke. He asks the doctor, when will I get completely okay? And the doctor says, no, I'm sorry to say, but this cannot be completely okay. That's not the way to deliver it. If you're a nurse or a counselor and a similar thing happens, the physiotherapist, the patient has been sent to you by a busy doctor because you've been asked to break the bad news. And you have to tell him or her the diagnosis, and your response is, your reports have come back today and have been handed to me by Dr. So-and-so, you have cancer. This is the worst way of breaking bad news to somebody, where we're deflecting or we're just being brutally honest about it. And bad news really is news which drastically and negatively alters a person's view of the future. And the greater the gap between someone's expectations and the reality of the situation, the worse the news will be. So if somebody's expectation is for recovery and the news is that they're not recovering, the worse the bad news is. If somebody had realistic expectations and the news is bad, that gap is less. Is that making sense? If someone has been given false promises right through, saying that you're going to be fine, you're going to be fine, you're going to be fine. And suddenly the test results come, they're not going to be fine. It's going to hit them much harder. Yes. I'm just going to quickly check. I'm very sorry to have gone over time. Are you all okay to stay for another 10 minutes and we'll just wrap this up? Is everybody okay with 10 minutes? Yeah, we'll close this, and I apologize for going overboard with the time. Okay, so very important question. We now know what is bad news. Who is the best person to deliver bad news? Those who the patients know and trust. Those who have the skill to convey the message. I mean, if the doctor goes to deliver the bad news and delivers it in a bad way, he was not the right person. But if the doctor is present in the room and somebody else delivers the bad news and the doctor is there to answer specific questions, that also works. Okay. Those who can handle the reactions effectively, like how we've said, don't rush in to comfort, don't rush in to reassure, offer them a seat, whatever. If somebody's angry, offer them a chair. So somebody who is skilled in handling big reactions. Those who know the disease prognosis and treatment. Now, this is what I'm saying. Sometimes it might be the social worker or the counselor who can deliver the bad news because I have a greater rapport, but there has to be someone from the clinical team who can answer questions pertaining to the disease as well. Okay, so in healthcare, that's a little bit of a tricky situation where a non-medical person cannot go and deliver bad news, because if they have questions about the disease, then they're not able to answer that. So always have someone from the clinical team. When should bad news be delivered? It's an ongoing process. It's not going to happen once over one conversation. Firstly, whenever the patient asks, you might be asked to repeat information. You have to do it, because sometimes if the news is bad, we don't always process it all together at the same time. You might have talked about a certain aspect, they might not have registered it, they will come back to you. You have to be prepared to answer that again. Provided the patient has been given the opportunity to ask. Very often the patient is not given the opportunity to ask. So give the patient the opportunity to ask. After that, if the patient asks you, you have to give them the news. What is the context within which you will deliver this news? Firstly, give them facts. Okay. Good idea of medical history and progress. You should have a good idea of their medical history and their progress. So you can say that, you remember this time when you came in with this diagnosis, and this is what we were expecting at that time. This is what the previous doctors had told you. We decided to do this. This is how your illness has progressed. So here we are now, and those are the facts. Environment, make sure that it's a quiet room, no disturbance, Spikes protocol. Who is going to be present, to be done by those who know how to do it. So these are the things that you need to consider. Have command of the facts, make sure the environment is correct, and make sure the people are right. Okay, all of these three things have to happen together. The framework, declare your agenda. Why are you here? Why are you meeting today? Today, I would like to discuss with you the reports of these tests which we did the last time. So where the person comes in, always declare the agenda. Invite the patient's agenda. Before we get started, I would like to hear from you what you are hoping to get out of our visit today. So you have your agenda, the patient. Before we get started with the test results, what were you hoping to get from our visit today? The answers you might get might be, I'm hoping that you can fix my insomnia. And I'm really hoping that you can tell me that everything's going to be fine, that that the results have come out okay. So at least you know the expectation. So we say, okay, fine. Let's get to the test results later. You are having issues with your sleep. Let's get that out of the way. Okay, now so you've actually taken care of something on their agenda, and then you move on to what your agenda is. Sometimes you have to negotiate the agenda, where the person says, today I've come to you, doctor, because I want you to fix my insomnia. I've not been able to really eat more than like a few handfuls of food. Plus, I'm really worried about the fact that as the disease progresses, then, I'm going to have to make these changes in my lifestyle. And plus, okay, we're just also the test results, right? Like you've got the test results. He's given me 4 things to talk about. I have half an hour. I cannot handle all 4 things. I need to talk about the stuff that is most essential. So at which point I will negotiate and say, there may be more on your list that we have time to discuss. Which items do you prioritize as the most important? He might turn around and say, my sleep, because if I can't sleep, then I can't function. So can you fix my sleep issue, please? So, so you prioritize stuff, get it out of the way. Invite other decision makers. Who do you usually rely on to help you make important decisions? This is in the context of bad news. When we discuss your results, who would you like to be present? And also remember that these are warning shots also, because this tells the person that what's coming next is serious. Okay. And in breaking bad news, is more information wanted? Do not withhold information if the patient or relative wants to know. But at the same time, do not what we talked about, so I'm not going to go into it in more detail. You fire the warning shot, they tell you no, respect it. Do not impose information on them. Nisha, I'm getting a message that my internet is a little unstable.
We've lost you right now. Maybe if you can switch off your
now. Okay. Okay. Let me know now.
It's okay. I think you can start speaking again now.
Okay, we'll
Good to go, yeah.
All right. I don't want to know, doctor. It is enough if you give me relief from pain. The conversation should end here. Okay. Finally, you need, after you've given information, you need to check. Have they understood? Firstly, have they understood check their medical knowledge. We've been talking about a brain stroke. Do you understand about the condition? This happens a lot, okay? Where someone will come, because when somebody is diagnosed with an illness, they will pick up the vocabulary around that disease. Will pick up the language. Have you noticed that? Manisha, just also let me know about my audio. Okay? Have you spoken to a caregiver of a cancer? They know. Sorry, they know from names to the markers, the biomarkers, the protein markers, all of those things. They'll rattle off the language of cancer to you. But if you stop and you ask them to break it down, if somebody is, if
you in between.
Okay, all right. Let me just try and.
Okay.
And check the difference. What do you want? The shot, it is worse than we thought. We are not.
Ma'am, your voice is breaking in between.
Okay, fine. How about we just 1 second. Give me 1 second.
Okay.
All right. The internet is telling me it's time up. All right. So let's just close this now. We've talked difficult. And these are response. We again, I'm giving you statements and no summary, a plan, avoid a brand before support. This last slide is, I think, really essential. Don't avoid eye contact. Make eye contact, but appropriate eye contact. Don't rush in to tell the truth. Gauge the readiness of the family. Okay, warning shot. Don't answer direct questions. When will I die or how long do I have to live? Ask a counter question like, why do you ask? Is there anything in particular that you want to do? Don't ask leading questions. Ask open-ended questions. Don't minimize the patient's problem. Don't get worried over such a small problem. There are so many people who are facing much bigger problems. You need to acknowledge and normalize a patient's emotional experience. Anybody in your position would perhaps feel this way. Considering what you're going through, it's normal to feel this way. Don't give false hope. Give realistic hope. Okay? Your disease may be progressive, but I'll do my best to keep you comfortable as long as needed. Don't assume that you know what their worries are. Ask what their concerns are. And you'll be surprised at what their concerns might be. So I'm going to stop with this. Thank you all very much for being so patient. And also thank you for being very interactive today. I promise you're not going to see me next week. We've staggered the session so that you don't get me every week. But if you have any questions regarding communication, any of this, we'll be sharing the slide deck with you. Please try and do that exercise with that case or with any of the cases that you might be encountering. And if you have any questions, you can always email Manisha and Senia and they will forward it to you. Thank you very much. And Manisha.
Thank you, Smriti ma'am. Thank you so much. And thank you to all for being so patient once again. And thank you all. See you. Bye-bye. And we've also shared the feedback link in the chat box. Please do fill it out. So thank you. Bye.